I'm Irene Malaty. I'm one of the neurologists that sees a lot of people with Parkinson's every single day. And, you know, a lot of times we get into more, we focus a lot on the latest in research and all that, which is really important, but sometimes it's not bad to just have an overview from the beginning again. Or what are the symptoms? What should we expect? What's typical? Sometimes people say, wow, I didn't know that could be related to my Parkinson's. And sometimes people will tell me, gosh, this thing can affect a lot of different areas. And it's interesting how something that starts in your brain could affect so many other areas of your whole body. And then we'll try to run through what are some of the medicines we use and the treatments. Can everybody hear me okay? Okay. If anyone can't hear me, just kind of go like this and I'll know to step it up. Okay, I'll do that. Okay, so, you know, I was asked to talk about Parkinson's symptoms and treatment in half an hour, and that's kind of tough. That's tough to cram all that in half an hour, but we'll do our best. We'll just talk about what are the motor symptoms, meaning movement symptoms, what are the non-motor symptoms, and then what are some of the treatments. So you heard already, Parkinson's is super common. So if you or someone that you care about has Parkinson's, you're not alone. There are thousands of people diagnosed every year. Every year, probably 60,000 or more people get told you have Parkinson's for the first time. And there are millions of people across the globe. Epidemiological studies, meaning studies that look at population and ages of the population, project that by 2030, these numbers will even double. That many more people will have Parkinson's, just based on the fact that we're all living longer, and now we're seeing more and more people with this condition. It's actually good when you have a condition to know that it's common, because it means there's more interest in research looking for new cures, there's more funding going into it, so that's a good thing. So the very basic symptoms that most people are somewhat familiar with involve tremor, but not everybody has tremor. A lot of people would say, how can I have Parkinson's if I'm not shaking? Not everybody gets tremor. The majority of the people do. Some people have rigidity or stiffness. Akinesia means a lack of movement, or bradykinesia, slowness of movement, taking longer to do things that involve physical movement, and changes in posture or gait. This is an older documented picture from 1892 that someone took a picture to show what some individuals with Parkinson's disease could experience with their posture. Early in Parkinson's, not everybody has all those symptoms at all. In fact, the first things people tend to notice are subtle things like changes in their handwriting, getting smaller or shakier, changes in the facial expression, being less expressive or obvious what the person is feeling by their facial expression, softening of the voice. Some people will feel stiff in one arm and they'll think they have a shoulder problem, or someone will ask if they've had a stroke because one arm may not move like the other one, and those can be early symptoms of Parkinson's. More prominent symptoms can be problems doing things with the hands, like buttons. Everybody has a hard time with the collar buttons and the sleeve buttons, and ladies with their earrings and sometimes their brassieres have a hard time with small things that require dexterity. The kinds of walking changes in early Parkinson's may be subtle, and it might just be one foot dragging a little bit or slowing down a little bit. As people have Parkinson's longer, they might experience shorter, more shuffling steps, problems with balance, sometimes posture changes, and sometimes when people have Parkinson's long enough, they could experience a problem called freezing of gait. It's a problem starting to walk. So when you've been sitting for a while trying to move, the feet don't listen, and it's hard to get going. We call that freezing of gait. And that's more common when people are changing direction or walking through a doorway in smaller spaces, but especially with starting movement. Not everyone with Parkinson's experiences these, but just to have heard of them, dystonia is a problem with involuntary muscle contraction, tightening of the muscles. A lot of times in the feet, this could be curling of the toes, cramping up of the toes. It's common as people's medicine wears off. Some people could have excessive blinking that we call blepharospasm, or tightening of the neck muscles that causes a tilting or a pulling in one direction. Dyskinesia is a problem that many people are familiar with by sight. If you've seen Michael J. Fox, a prominent actor, can have involuntary wiggling movements. That's what we call dyskinesia. It means abnormal movement. People will typically experience that when they've had Parkinson's a long time at the peak of their dose. So when the medicine kicks in at its strongest, people can experience those movements, and then as it wears off, they typically settle out. And this is just a picture to explain that in what we call the therapeutic window means the difference between too much medicine and too little medicine. So you need enough to get a benefit, but then too much people can have side effects. And in early Parkinson's, it's easy to stay in that range. You take a dose, it gives you the benefit, it wears off. You take another and you stay in that good zone. But the longer people have it, it gets tougher to keep things just right. And it's more likely that people may experience potentially those dyskinesias or side effects when the medicine's at its peak, but then it wears off more quickly than it used to, and people tend to need to take medicine more frequently. In early Parkinson's, sometimes people might say, I miss a dose and I don't even notice the difference. But if your symptoms are there long enough, it's more common that people feel what we call wearing off, where you notice feeling tighter in the muscles or slower or shakier as the medicine wears off. So everybody's kind of familiar with the tremor and the walking and those sorts of things, but a lot of people aren't familiar with the fact that Parkinson's can affect a lot of other things as well. 98% or more of people with Parkinson's have at least one non-motor symptom, at least one thing that bugs them besides tremor, walking, or posture. And these things have been shown to be even more important sometimes than the walking changes. One of the earliest symptoms of Parkinson's may be a loss of the sense of smell. And if you think about it, some people will say, yeah, food doesn't taste as good as it used to, or I used to really notice when my wife was cooking or my husband, and now I'm not smelling things as well. And it turns out that's one of the earliest symptoms. Now, other stuff can cause that too, so if you don't smell well, it doesn't mean you're going to get Parkinson's. People may experience abnormal feelings in their legs. Restless leg syndrome is a problem where you feel just this antsy, uncomfortable feeling. It might be a cramping, it might be a creepy, crawly sensation that is relieved by getting up and moving around. And sometimes that can be a clue that the person needs an adjustment in their medication. Restless leg syndrome, again, is really common even in people who don't have Parkinson's, but it's more common in people with Parkinson's. Visual hallucinations are more common related to the medicines that are used to treat the condition when people have had it for longer. And when people do experience that problem, it's different than people who have hallucinations from other sorts of illnesses. A lot of times it's just seeing a child or a person that you think may have gone by and you realize it's not really there. Sometimes it could be more significant, but if it occurs, it's treatable. We can help manage that, so you should always tell your doctor if you experience that. So it's interesting that one study has shown that constipation, the lack of the sense of smell, and troubles with movements during your sleep really are predicted. Those are really common in early Parkinson's, even before all the other stuff shows up. And some people in the room might say, yeah, I remember I experienced that a long time ago, even before someone told me I had Parkinson's. Some people can experience accumulation of saliva or even drooling, and that's not because they make more saliva. It's just because you normally involuntarily just swallow all the time without thinking about it. And if you slow that down, it can get produced quicker than you swallow it, and people could have that. There are some treatments for that. There are some drops, there are some injections if it gets really significant, but usually it's not to that degree. Swallowing trouble is incredibly common and super important in Parkinson's, and the reason is we always tell people Parkinson's doesn't kill you. It affects your quality of life and how you do things, but it's usually not a life-threatening condition. But there are some reasons it can be life-threatening, and that could be serious falls or problems swallowing that lead to pneumonia. We call that aspiration pneumonia, when things go down the windpipe instead of the food pipe. And so if you're seeing someone who knows enough about Parkinson's, they may encourage you to have your swallow checked periodically, and certainly if you're choking or coughing when you swallow. Constipation is really, really common. It's common in the age group that tends to get Parkinson's, and it's even more common if you have Parkinson's. And it's important to treat because if it's very severe and people have such delay of their gastric motility that it's significant, it might affect how they absorb their medicine. So sometimes we need to look into that. Sleep disorders are more common in Parkinson's than people who don't have Parkinson's, and those can include just problems getting rest, insomnia, restless leg syndrome that we talked about, or a condition called REM behavior disorder. REM stands for rapid eye movement sleep. It's the sleep where you're dreaming, and you're kind of supposed to be paralyzed when you're dreaming. If you see me dreaming, I'm probably not obviously doing what I'm dreaming about. But if you have this condition, you're not paralyzed, and you punch, move, kick, talk, and do all sorts of things in your sleep. And it's not usually the person who has this problem that complains about it. It's usually the other person in the bed. And sometimes I joke that I can tell how bad it is by how many pillows the spouse is stacking between them to keep from getting punched or hit. And it can be funny sometimes to talk about, people have dove out of bed thinking they're swimming or they're in a fight and they're running. But it's actually serious because it can affect the restfulness of the sleep. And a person can end up sleep deprived even though they felt like they clocked in enough hours in bed if this isn't treated, and it is treatable. Fatigue is one of the most common and most difficult symptoms to overcome in Parkinson's, just feeling tired. It's a combination of the Parkinson's itself, and sometimes even the medicines can contribute to that too. And mood trouble, depression and anxiety, and what we call apathy or loss of motivation. Dr. Bowers will talk a little bit about that in a while. These conditions are very common in Parkinson's, and they've been shown to be more important for a person's quality of life than anything else. Depression is more common, is more important. So if you have untreated depression, everything else is going to be worse. It's important to address it when it's present. These can occur not just as a reaction to Parkinson's, because some people say, well, yeah, if you got Parkinson's, you don't want to have it. That could be depressing. But it's not even just the reaction. Even people who are doing very well could experience this problem. It's a symptom of Parkinson's disease, and the changes in the brain physically cause depression as well. And it's so common that the National Parkinson Foundation, someone in this room may be a participant in this study, the registry, where once a year you walk a short distance in time and remember a few words and share the information of what treatments you've had that last few months. They're looking at thousands of people with Parkinson's to figure out what's common, what works, what should we be talking about. And it turns out that of the people they studied, 40% of people had symptoms of at least mild depression, and 60% had some depressive symptoms. So that means out of 10 people, 6 out of 10 are having some symptoms with depression, and 4 out of 10 it's important enough that you could diagnose something. So that's how common it is. Despite it being that common, at all of their centers of excellence, the places where the most expert people are for Parkinson's, there's a lot of variability, from 40 to 80% of people actually are getting treatment when they have it. So even experts are forgetting to address this really important problem. You need to bring it up if it's present. And the last symptom I'll mention is what we call autonomic nervous system trouble. This is the part of our nervous system that just regulates stuff. It keeps our blood pressure regulated, our guts moving, our temperature regulated, our sweating regulated, and it can get out of whack in Parkinson's. People's blood pressure could go very high and very low in the same individual, even within a day. Another common symptom that we call orthostatic hypotension means when people stand up, their blood pressure can drop and they can get woozy or dizzy or lightheaded. There are treatments for these conditions. Some of them are medicines and some are not even medicines. So when you have these problems, it's important to discuss them. And sexual dysfunction, primarily we're talking about erectile dysfunction in men, can be a symptom related to Parkinson's. The treatments are the same as if it's caused by something else. So you can still talk about it with your primary doctor, urologist, or even your neurologist. And cognitive troubles I'll mention briefly because Dr. Bowers will spend time talking about them. Most people in Parkinson's do not have the types of cognitive problems if you think of someone with, say, Alzheimer's type dementia. This is a different type of cognitive trouble. The most common is taking a little longer to think of what you want to say, or trouble thinking of the word you want to say, what we call tip of the tongue phenomena, where it's there, you just can't think of it. And those are the most common, or trouble remembering to plan and follow through on things. It is possible to have severe cognitive problems, even dementia, but not everybody experiences that. But these are things that also you can talk with your doc about.
So if we knew all that, we wish if only brains grew on trees. This is a plant I saw in Aruba that to me looked like a brain. And I thought, wouldn't that be nice if we could just replace them? But we can't, so we have to talk about treatment. So Parkinson's mostly affects people that are above 40 years old, usually even above 60, but it can start very young. Everybody wants to know, well, what causes it? And the short answer is we don't know. There's a lot of research looking for why. There's a lot of theories. We know that genes are part of the answer. We know that genes make you a little bit at risk, but there's something beyond genes. We don't know if it's toxins that we're exposed to. We don't know if it's something that gets passed, risk gets passed, like when you get viruses and other things. Nobody knows at this point. There are lots of genes that have been studied, and in each person with Parkinson's, it's not the same genes that necessarily put them at risk. So there are many different genes. All this research is important because it brings us a little closer. They're all clues. If we know that a gene is more likely to cause Parkinson's, and we say, well, what happens when you change that gene? And whatever we figure out, we know, well, then that must be important for Parkinson's. Maybe that can be something treatable. So they're all clues. We do know that under the microscope, if you take someone's brain that used to have Parkinson's, look at it under a microscope, we see these little protein deposits that we call Lewy bodies. There's a doctor named Lewy, and he figured it out and named them. And we know that this is a brain stem, the back of a brain cut up. This is normal. Oops, this area called substantia nigra should be black. And you can see that when you have Parkinson's, it's not as black because there are loss of some of those neurons that have that pigment. But that's just one small part of it. There are changes throughout the brain that can be happening. There are a lot of other conditions that mimic Parkinson's. So just because you have tremor, just because you have walking trouble, it doesn't mean it's Parkinson's. There's another condition called essential tremor, which is just a tremor condition that doesn't involve the slowness and stiffness and gait changes typically. Sometimes people who have Alzheimer's have a little tremor, but it's not Parkinson's. Sometimes people could have both. Lewy body disease is a condition where people tend to have early dementia and hallucinations and similar symptoms to Parkinson's that can confuse us in the beginning which one it really is. There's a condition called corticobasal degeneration where people develop Parkinson-like symptoms, but when you use Parkinson medicine, it doesn't tend to get better as well. And that can be a clue that it's not actually Parkinson's. They have a lot of the dystonia that I mentioned and sometimes jerking movements. I could go around this and tell you all of them, but the bottom line is sometimes it's not Parkinson's, so it's important to see a neurologist. It's actually been shown in a study. People who saw a neurologist for Parkinson's versus people who didn't actually did better in terms of falls, quality of life, duration of life. So it is important to have someone who knows what you've got taking care of you. Also to make sure which of these it could be. So I want to make sure we have a little time to go over some of the medicines. Okay. Briefly, how is it diagnosed? There's not a blood test for Parkinson's right now. There's not something that I can do that I can tell you 100% that's what you have or not. It's what we call a clinical diagnosis. We base it on the symptoms you tell us about, the observations that an expert makes examining you, and what happens when we give you medicine for Parkinson's. So in the early stages, there should be a benefit with Parkinson medicine if that's what you have. Now, if it's too early that you don't have a whole lot of symptoms to begin with, then it's harder to tell if it's helping or not. But if you have enough symptoms to give you trouble, we should be able to see some change with the typical medicines if that's what it is. There are some tests that can be done. Sometimes we'll do an MRI of the brain just to make sure there's nothing else going on, that you haven't had a bunch of strokes. People who've had a bunch of strokes can kind of look like they have Parkinson's when they don't. There's a scan called a DAT scan. It's dopamine transporter imaging where people get a tracer that goes to the dopamine nerve terminals and looks different if you have Parkinson's or don't. There's a scan called a PET scan, but usually we don't have to use these unless we're just not quite sure. And those scans are not 100%. They help support what you already suspect. And this is a picture of a DAT scan. On the left, it looks bright because of a normal uptake, and on the right, it looks dull in an individual with Parkinson's disease. So the treatments can be pills. We call that pharmacologic treatments. There's even surgery, deep brain stimulator surgery, and then there are other things beyond pills and surgery. So the myths I want to make sure that we talk about are, this is a common one for people with early Parkinson's, is delay medicine just as long as you can. Hold off as long as you can, no matter how miserable you are, and that is just not true. Some people feel like the medicine is going to make them worse. And the medicine is not toxic. The medicine does not advance the condition. The longer you have the condition, it continues to change with or without the medicine. And the response to the medicine is going to be different if you've had it 20 years than when you've only had it 5 years. You shouldn't take more medicine than you need or start it when you don't need it. But if you're having symptoms that affect your quality of life, it's important to treat them. What we know for sure is staying active and mobile and exercising and being involved in your normal life activities is the very best thing that you can do for the long-term course of your Parkinson's. So if you're letting symptoms get to the point that you can't engage in the things you normally would, that means you really need to be talking about doing something differently. And some people believe that if you're young, you can't take cinnamon or levodopa, and that's not true either. It depends how you've done with other medicines. It depends if your symptoms are severe enough that that's the best medicine to start off right off the bat. Sometimes it is the right choice. And the other thing that's one of the most important points is don't look at your neighbor. Put your blinders on and just imagine that you're on your own course. Because some people say they might be 40 and working and have children and they have Parkinson's. And they might see someone who's 95 and had it for 30 years and they might think, oh my gosh, I'm going to have the same situation as this person. Let me just go ahead and just want to make sure you can hear everything. So you might see someone who has a very terrible situation. They may have a lot of other illnesses. They may not be taking medicine. You might worry, is that going to be me? And you just have to understand there are some things that are common in many people with Parkinson's, but everybody's story is different. Of 100 people, their experience, their course is going to be different from the next. So you can't say, well, my neighbor took Cinemed and he felt terrible. That means I shouldn't take Cinemed. You have to remember each person's different. The other thing is the concept of on and off. We use the phrase on to talk about how people feel when their medicine is effectively working. And for many people, they feel they can move better, they may have less tremor, they may have less tightness in their muscles. And as their medicine wears off, after several hours, they may experience tightening of the muscles or stiffening or more trouble moving. So when we talk about on and off, it relates to the fact that when people have had Parkinson's long enough, they may really perceive a significant difference in how they feel with their medicine compared to how they feel without it. And when you see your doctor, it's important to talk about how well you feel when your medicine's working and also how long it lasts when you take it. Is it wearing off before the next dose, or is it staying nice and steady? Because sometimes we need to raise how much you get at each dose, or sometimes we need to dose more often. And that's different depending on what you're experiencing. Some people could have wearing off all of the sudden. And it's important to know what patterns your body has, because you might plan. If you're going to do your groceries, you might want to do it when you know your medicine's at its best. The other thing is, if you tell your doctor it's always at 2 o'clock that I have a hard time, maybe we just adjust that particular dose that influences that time of the day. And there are even medicine options that are specifically for wearing off suddenly. And also an important lesson is there are going to be good days and bad days. And this is important for people with Parkinson's and for people living with people with Parkinson's. One reason is you might say, my husband, he mowed the whole lawn Wednesday. He's just lazy. That's why he doesn't want to do it today. And that might be true, but sometimes it's just that on a different day, the capacity and energy level is just different from another day. And there are some days you feel on top of the world and you can do everything. And there are other days that it might be a rockier day. And you have to be prepared for that and just accept it and just plan, you know what, today I don't think I can do that. You should push yourself a little bit, but you have to give yourself, the understanding that there will be good days and bad days. Okay. In our last few minutes, I want to just mention the treatments and also what is deep brain stimulator surgery. This is just a list, but we'll go through them one at a time just so you've heard of them. Amantadine is a medicine that was invented to treat the flu. And it's not helpful if you have the flu in today's world, but at the time it was, and it just turned out that it was a good Parkinson medicine. This can be helpful when people have mild Parkinson's and it may help their tremor, or when people develop dyskinesia, it can be helpful. Some people could have side effects that could include cloudy thinking or hallucinations, but not everyone would experience that, so this may be an option. Benztropine or trihexyphenidyl, also known as cogentin and Artane, aren't used as much today, but they're some of the oldest medicines that have been used for Parkinson's, and they're usually used in very mild Parkinson's. They can also have problems with hallucinations and cloudy thinking or urinary retention, and so we tend to be cautious in using those. Some medicines work by slowing down the way your body gets rid of dopamine at the nerve terminal. And there are two enzymes that break down dopamine, and so if you slow down one or the other, your dopamine can last longer and be more effective. And these fall in the categories of monoamine oxidase inhibitors or catechol-O-methyltransferase inhibitors. And their names are selegiline and rasagiline, and they're dosed once or twice a day, twice for selegiline, once for rasagiline. And they're very mild medicines. They tend to be very well tolerated. There's been some theory about whether they slow down Parkinson's. They're probably mostly just helpful for symptoms, but they can be an option in early mild Parkinson's. They also sometimes can help when wearing off, when people have wearing off of benefit to make their dose last longer. Entacapone or Comtan can make people's urine orange, so you have to know that that's okay. It can cause diarrhea, also a risk of hallucinations or dyskinesia, like all of them. But anytime people have a side effect, if you stop the medicine, it goes away. So that's important to be aware of. Tasmar is an older one we barely ever use anymore because it could cause liver toxicity, but people can take it with blood monitoring. The dopamine agonists are medicine that stimulate dopamine receptors. We have some that are pills called Mirapex and Requip, or pramipexole and ropinirole, and they all come in short-acting and long-acting forms. And there's a patch called Nupro or retigatine. The patch is once a day. You put it on and it lasts 24 hours. And it can help in earlier Parkinson's, or it can help with avoiding wearing off or for restless legs. Apomorphine is one we don't use very often because it's an injectable medicine. And we only use that in rare instances where people really truly have very sudden wearing off. They're out and about and suddenly everything wears off and they may be frozen, and that this injection might get things going again for a short period of time. That has to be treated for the first time in the clinic where we can check blood pressure and make sure people do okay with it, because it can cause blood pressure drops or nausea. But the dopamine agonists, they're very good medicines, but they do have interesting side effects when they occur, which is of course the minority. Most people can take them, but they can cause tiredness or even sleep attacks. That means just falling asleep in the middle of stuff, falling asleep at the computer, for instance. The other side effects could be swelling, low blood pressure, dizziness, nausea, or people could develop urges to gamble or spend money or have preoccupying sexual thoughts. And these happen because dopamine is a neurotransmitter that's involved in things that are rewarding. It's involved in addictions and compulsions. So when you take the medicine, it's like an artificial stimulus of those receptors. Instead of being steady all the time, it's like pulses periodically. And people can develop these compulsive eating or spending. And when it happens, if you stop the medicine, it goes away. So the only reason it's very important is if you didn't know it was a side effect, you might not tell your doc about it. You might think it was just a personal issue, when really it could be a medicine side effect that could completely go away when you make adjustments.
What's punding?
Oh, you know what? Punding is something that's pretty rare. It's a senseless manipulation of objects, like taking stuff apart and messing with the parts and putting it back together without a real purpose. It's pretty rare, but it's one of the things that's been documented. And finally, the most effective medicine is levodopa. Levodopa is converted to dopamine, so it helps replace the dopamine. It comes in several formulations, and it's always combined with carbidopa. So carbidopa is just there to prevent nausea from levodopa. And syn-emet means without emesis. So when they put they figured levodopa could make people better. It was the biggest discovery, the most wonderful thing, but people were so nauseated they couldn't tolerate it. So when they figured out you could put carbidopa with it, and then you don't make dopamine in your belly, it goes to your brain and converts to dopamine in your brain, it's a wonderful breakthrough. So it comes in short-acting or immediate release and long-acting, controlled release. It comes in a melt-in-your-mouth form called Parcopa that disintegrates if you can't swallow pills, and it's being studied in a gel form that is a continuous release system. And the side effects could be nausea, dizziness, lightheadedness, hallucination, dyskinesia. But all of these things can be addressed and modifications can be made to help overcome them. So we're pretty much out of time, but briefly, I'll just go through the last couple things very briefly in 1 or 2 minutes. We add levodopa when the symptoms are significant enough that you need something that's going to be effective. When the other things don't work, or you have side effects from the other things. And you might wonder, well, when do people consider that surgery, deep brain stimulator? We consider that when dyskinesia is significant and we need to reduce that. It's effective at reducing dyskinesia. Or when people have a lot of fluctuations. The medicine works very well, but it wears off and it goes ups and downs all day long. It helps people stay with that good on. Now, it doesn't tend to get people even better than the best they get with medicine. So if you have symptoms that no matter how much medicine you take, they're still there, it's not that surgery will improve those symptoms, but it will help keep a more steady response. And just to show you what it looks like, if you see this little cartoon, there are these electrodes implanted in the brain and connected by a wire to a battery in the chest that puts electrical pulses out that stimulates the areas of the brain involved in Parkinson's and improves the symptoms. This is a lady going through the surgery. She has a head ring attached that's used to map the areas in the brain that we know are important. She's getting a picture taken, an MRI and a CT get taken of the brain, and the computer models that person's brain and the targets to put in. And this is just the operating room. People are awake during the surgery. Your brain doesn't hurt when you touch it, just the skin and the tissues do, and all that gets numb, but people are actually awake while their brain's being operated on. And they're even talking and interacting with the surgeon. And this is just a picture of how it looks once it's implanted. The side effects could be anything that relates to trauma to the brain, so strokes and seizures and bleeding and infections, and even worsening of things like gait and speech. So we're very careful about considering surgery. We go through a whole team of assessment of how people are doing with walking, swallowing, thinking, mood before we go into surgery, and we counsel them about the risks and decide one-on-one if it's the right thing to do. And just finally, remember, there's stuff besides pills. You heard about wellness. We have a bunch of programs, and it doesn't have to be here. It can be on your own. We have singing group, dancing group, art group. We have exercise group. It's important that you fill your life with things that keep you active and engaged and happy. And just remember, there's all kinds of research all across the globe. People are researching this condition and looking for cures and treatments all the time. So thank you for coming today. Dr. Bowers will be next. Now, if you have questions, don't forget to write them down because we have a whole hour during your lunch. We're going to sit up front and answer all your questions about Parkinson's and the treatments. Thank you for coming today.